How do we erase the stigma around women who are pregnant coming into treatment?
So much has changed in women's issues. One of them is the prevalence of substance abuse.
And there's nothing more tragic than seeing an overdosed mom in the ER who's potentially unrevivable. Her unborn child suffers the consequences as well.
As you guys know, my name's Richard Taite. I'm the founder of Carrera Treatment Facility, and I call this podcast We're Out of Time. And the reason I do that is because we actually are with this fentanyl crisis that we're having. I mean, the opioid epidemic has been going on for a while, okay? But now it's killing everybody with fentanyl. And, when you were back in the day, when you were scoring cocaine or heroin or pills off the street, it wasn't, you thought you were getting it. You were getting the Percocet, you were getting the heroin, you were getting all these drugs. Today, that's not what you're bargaining for. Okay. It's being laced with fentanyl. It's killing about 112,000 people a year, right? And it's increased 30-fold over the last, 10 years. And most of it has been in the last 5 since I've been gone. And one of the reasons I came back was because of this. Okay, this is Dr. Blair. She's a psychologist, fantastic. She's been doing this for about 20 years. This is Dr. Kenneth Spielvogel, one of the finest women's physicians in the city. And let's start with Dr. Spielvogel.
Good morning. Thank you for having me.
That's my pleasure. Thanks for being here.
Yeah, I mean, this is an epidemic, and it's in the realm of pregnancy and delivery. It is a unique problem because in my job, it's a unique area of medicine because we treat at least 2 patients at once. We'll have a mom and unborn child. If it's a singleton, if it's twins, triplets, obviously that brings more individuals that are affected into the picture. So, this problem I've definitely seen, the pandemic weirdly kind of brought a certain quiet to it, and it's definitely started to rear its head up again. And there's nothing more tragic than seeing an overdosed mom in the ER who's potentially unrevivable, and, her unborn child suffers the consequences as well, too. So, I wanted to be involved. I wanted to have a voice that extends well beyond the hospital. So I really appreciate you having me here.
No, it's my pleasure. Thanks for adding to the conversation. Blair.
Yeah, so much has changed with time and women's issues. And one of them is the prevalence of substance abuse in women. And women, as we know, are mothers. And there is a lot of stigma attached that can really prevent someone from seeking treatment and asking for help. And some of it can come from extremely well-meaning practitioners.
Especially when they show up to treatment pregnant, showing.
Yes.
Right? Because there's so much judgment around it.
There is. And you have to be aware of that and work through it. And to be honest and vulnerable, I've had to work through this myself. And it's very important that I get to the place that this person needs and deserves as much love and care and attention as anyone else.
Yeah. Someone asked me last week, they said, what's one of the biggest barriers to treatment when it comes to opioid addicted moms? And I said, judgment. Mm-hmm. Honestly, judgment is probably the biggest one, because I can walk in a room, introduce myself to every family member, to patient, really get on a level to where they feel safe and cared for and in a judgment-free environment to do so, which honestly, to get a patient who's addicted to trust their healthcare provider is an incredible challenge. And especially when you mix in race and we look at the outcomes, especially for African-American women these days, and that they clearly have a disparity when it comes to healthcare. being able to bridge those gaps and get to a place, have them feel safe and cared for and trust you. And then you leave at the end of your shift and someone else comes in and that trust is eroded instantaneously with the person walking in the room. I mean, that's the biggest barrier. It takes more than one person that's willing to come at it from a judgment-free point of view.
True. And AI, which is scary in a lot of domains, I find is helpful when it comes to this. I think AI will really help when it comes to stigma and judgment.
How so?
So, heart disease, for example, is the leading cause of death in women. And to this day, a man and a woman can enter an ER with the same symptoms, chest pain, etc. And he will be screened for a heart attack and she will be screened for a panic attack. So if we can have, right, it happens. So if we can have AI just read symptoms by symptoms, not with race and gender and socioeconomic and everything else, I feel like that gives some hope to people receiving the treatment that they need.
Yeah, it's ridiculous how women, it's funny. I had somebody bring in my dry cleaning, right? A woman bring in my dry cleaning, and it cost 3 times more for her than it cost for me. Right. And they do that at mechanics too. Like women get the short end of the stick.
Hairstylists.
Everything. Yeah. Women get the short end of the stick everywhere. How do we go ahead and erase the stigma around women who are pregnant coming into treatment?
Well, it's vital. I mean, it's because the majority of women who are using will not come in for prenatal care. They'll essentially show up for delivery, or if they're having an acute episode, vaginal bleeding, contractions, whatever it may be. That's the biggest stigma. I mean, it really is. It's getting women to a place where they, are being treated for recovery. If they're, on buprenorphine, that they feel like they can come in. If they're requiring an additional dose, that's done without kind of any judgment. And that's around, to me, it's around education and, an awareness of the pathophysiology of addiction. I mean, it really is. And I can tell you, if you asked, what's the amount of hours that I received training in specific to addiction during a 4-year residency?
1 hour.
Well, my answer would be, we do a internal medicine rotation as an intern, your first year of training. And essentially, somebody drunk comes in the ER, you admit them for, treatment of withdrawal, very patient specific, probably totals about 4 hours.
In 4 years.
In 4 years of when I trained 90-hour work weeks.
Right.
So there's no understanding.
Wow. I hear often working with clients who have to go to the hospital, and when addiction is the primary diagnosis, right, substance use disorder, they feel like they're treated like second-class citizens, kind of thrown in the hallway, not given the attention. And I truly believe that healthcare professionals are well-meaning, but we're still human. So to answer your question, I feel like talking about it and injecting it with compassion is essential to getting people aware of where their biases are. Not if, but where. Right? And bringing it to surface, bringing it to light.
I find if you relate it to a disease that people are already well versed in, that's a good way to do it. So what's a good example of that? Diabetes. Somebody's diabetic, they take insulin for their diabetes. Nobody looks at a person who's diabetic and on insulin and says, why are you on so much insulin? Like, why are you on 120 units a day? Let's put you down.
That's not true.
Let's put you down.
People are getting fat shamed all the time.
They may be getting fat shamed, but point being is there's a recognition of a chronic illness. Right. This is the treatment
in the medical community. Right. Okay.
So now you take somebody who's pregnant. Maybe they're already having, medically assisted recovery, and they're on buprenorphine, they're on 8 milligrams a day, and they walk into an uneducated provider in the first trimester who says, oh my God, you got to taper down. We got to get you tapered down. Can't be on that during pregnancy. What do? They start tapering the patient down. They start to experience withdrawal symptoms, uncomfortable. Then the trust erodes and that patient disappears. And they show up at the hospital in labor, no prenatal care, and all the associated complications thereof. So understanding there are some people that will be on it for life. That's their affectation. That's the medication that they take to treat it, just like we treat high blood pressure, just like we treat diabetes.
You know what it is? They come in, I think you get pregnant if you're going to carry it to term, right? There's a part of the mama bear inside of you, right? And it's protective and right. And so then what happens is they feel such shame, right? That they're not coming to you in the first place. And so really what we got to do is it's got to be the same exact thing that we did to erode substance use disorder in the first place, which is you're not bad. You're just sick, right? And now, like you said at the beginning, it's affecting more than just you. And what scares me the most why you're here is because I'm a father. And when you're as old as I was when I had kids, you don't just love your kids, you love all kids. And I am desperately passionate about this opioid epidemic and specifically the fentanyl thing. It's causing more homeless, which I'm also passionate about. And if I see another child on the street in an encampment, I'm going to snap, right? I see that all the time. But this is so bad because they're being born with birth defects, right?
Birth defects, where there's smoke, there's fire. So somebody that's using is probably doing other harmful behaviors that potentially could contribute to an unhealthy pregnancy.
But they're doing other harmful behaviors because they're loaded, right?
Right. Yeah. There's any number of reasons. Women, I'm sure you know this, Blair, women who are addicts tend to use with their male partner, which is interesting because men generally use with another male compatriot. So women are using with their male partners. With that comes intimate partner violence. We see much more of that. We see much more smoking, poor nutrition, unstable housing, unstable food source. So all of that is going to contribute to, a poor outcome in pregnancy.
Right. And we're assuming here that the woman chose this pregnancy. We're assuming that she's aware that she's pregnant. We can assume that someone who's engaging in high-risk behaviors and not necessarily aware of the timing of things is likely having poor nutrition, which affects someone's menstrual cycle. So let's say she's been irregular for a long time. There's a chance that she wouldn't even be aware that she's pregnant until 5-6 months in, until you're showing.
But when you're 5-6 months showing, and you're already in the grips of addiction in the first place, right? How do we make it so that we can draw the distinction between, oh, you just found out that you're showing. This is different. Now this is going to affect your baby. She's going to be born, or he's going to be born, or they're going to be born addicted. And the withdrawal is painful. And I assume that sometimes that results in a fetal death, right?
It can, for sure. Any of all the reasons that I named, more than on several occasions, I have seen moms come into our OBER with a deceased fetus.
So how is it in a hospital setting? How can we get somebody like Dr. Blair in there so that on the first time they come in, right, they meet with somebody like you and you sit down with them and you connect one-on-one and you give them the reality of the position they're in and how to deal with it, maybe refer them to, a treatment center, right? Isn't that something that, a hospital administrator would be open to?
Yeah. I mean, so if a patient comes in, let's say they're untreated addict, pregnant. I literally just had this patient a couple of days ago. Come in, the first barrier is, do you want treatment? Are you willing to be treated?
Wrong question, man. Wrong question. Nobody wants treatment. Okay. The only thing harder to sell than treatment is adult circumcision. I'm not even kidding. Swear to God. It's the hardest thing.
I can tell you that in my experience, though, in the OBER, when a pregnant mom comes in who's using and in withdrawal, she's amendable to treatment. Like, she's amendable to treatment.
She's having a moment. It's called a moment of clarity. Okay. If you don't take her right there, if you can't transfer her right there to a treatment center, that moment passes like a cloud, just goes, right? So is there an apparatus? You're a teaching doctor there. They revere you. Okay. Is there a way that maybe something like that can be put into place that somebody who's skilled like Blair can meet with them one-on-one, right? And then you make the referral right away to wherever you think is appropriate. And there'll be like a transfer portal, right? We know of those things, right? A referral portal, right? And so you take that, you look into it, you do your assessment of where is appropriate for her, right? And you arrange for the pickup, right? And she's transferred immediately.
It sounds ideal. It really does.
Well, that's what this is about. It's about solutions.
Well, great. Even would you say, I'm curious. So I hear this from patients a lot, that they'll go see a provider and actually the provider is inputting a lot of data and they're seeing someone's back. Mm-hmm. Is that accurate?
Sure.
Yeah. So we've got so many things to do before this. I mean, this is phenomenal.
Right. But I want to get back to that. I want to get back to the solution. I don't want to veer off.
So step one is if somebody
do that, right?
Yeah. If somebody comes in, like I said, in withdrawal, data shows the opportunity to get them on a medically assisted program is right in that moment.
That's right.
And that means starting them, I'm going to be very specific with you. So starting them with 8 milligrams of buprenorphine right there. Treating other symptomatic elements of withdrawal, nausea, vomiting, whatever it may be along the way. Waiting 1 to 2 hours, seeing how they react. If they're better, but still feeling edgy, agitated, whatever it may be, another 8 milligrams.
Why not 4?
Generally, I mean, there's a lot of different ways to skin a cat. You can do 4 every hour. You can do 8.
Do it based on weight and all that other stuff.
Yeah, I mean, 8 milligrams. The great thing about buprenorphine, you're not going to overdose them, right? So it has a ceiling effect. So buprenorphine has a very strong affinity for the mu receptor, which is the primary place where opioids act. So the reason why it's so important, and I would say I'm going to go with 92% of healthcare providers don't know this. The reason why buprenorphine is so great is because it locks onto that receptor. And if that patient leaves for whatever reason, their partner, whatever outside influences, goes and scores a bunch of heroin laced with fentanyl, listen to me, they're not going to die. Because buprenorphine binds to that receptor, it's protective. So it will prevent an overdose. Had Philip Seymour Hoffman, had Prince been in recovery on buprenorphine, they'd probably still be alive today.
But isn't it, I get that. And I didn't know that. Okay. Isn't it, if you're not taking Suboxone at the same time every day with the same dose, and you're taking it, early, you're like walking around 2/10 high?
No.
Why?
It's just not the mechanism of how it acts. Generally, it's a suppression of symptoms of withdrawal without necessarily a supratentorial sense of being high.
Okay, well, that you're going to have to explain.
Right. So that's it being a partial agonist to that particular receptor. So that its mechanism of action is such that it's not going to be a high as you would get, a dissociative high that you would get with heroin, fentanyl, whatever it may be.
So isn't it like modern day methadone?
No. So that's a good question. So methadone is going to fall. First of all, methadone is a synthetic opioid. It binds weaker to that receptor. So the danger of methadone is that somebody could be on methadone, go out and score, use, and still have an overdose episode and die.
So why is anybody using methadone anymore?
Well, we're not. So,
there's there's methadone clinics.
Yeah, there are methadone clinics, but definitely within the realm of, the focus on pregnancy, delivery, opioid addicted moms, buprenorphine is drug A of choice. So here's an example of methadone. So here would be an example of methadone. You have, let's say, somebody who had a hip replacement that got, 45 oxy to go home with, got 3 refills from a neglectful provider and gets addicted to opioids. So that's the patient where methadone is really going to be appropriate.
Because it's a titration.
Sure. It gives you long-term pain relief. You can dose down. So we have very specific protocols for 30% reductions over the course of 3 weeks and really trying to get somebody off. So buprenorphine, again, that's where I get into this insulin diabetes analogy, is buprenorphine is for primarily that management of the symptoms of withdrawal.
Okay, but here's where I need the distinction drawn. If you've got somebody coming in, right, a mother who's pregnant coming in, and she's taken, 320 OxyContin, right, a day, right? She's loaded, and she's going to have a withdrawal if she's done it for any length of time, right? Why would you not detox her with the methadone if that's the way you do it with other populations? Isn't she going to, how would you assist that detox process with a pregnant mother?
Great question. So, and that's the very reason a pregnant mom, why we want to use buprenorphine, because when it comes to neonatal abstinence syndrome, which is essentially infant withdrawal from chronic opioid exposure, using buprenorphine, we see less neonatal abstinence syndrome. Babies spend less time in the NICU, fewer days of withdrawal symptoms, and less narcotics.
Yeah, but she's suffering.
And less narcotics in order to treatment. So that's why we want to use buprenorphine. And then with the 8 milligram titration protocol that I gave you, those moms get to a place where they're not experiencing withdrawal symptoms, and they have enough of an effect not to be loaded per se. But you have to remember that when you're an addict, a lot of times you're using to prevent withdrawal. You could have a mom who's tortured by the fact that she's having to take 2 oxys every 2 hours, right? So she has now been treated to where, oh my God, I'm not getting jittery. I'm not getting crave.
That's an excellent point, right? So she's using, right, to not just stay high, but to keep from getting sick.
That's the primary motivation.
Of course. So my question then again is, what do you use along with buprenorphine to detox this woman so that she's not suffering? Because it would seem like, yeah, it's better for the baby, but it would have been better for the baby not to be using in the first place, right? So how do you assist this process of buprenorphine with what other drugs to keep the mom comfortable so that she sticks with it?
Right. Great question. So we'll use buprenorphine, and then we'll use hydroxyzine, which is Atarax, which is essentially like a Benadryl type drug that actually works really well. We'll use gabapentin.
Which is?
Gabapentin is essentially, it's used as a pain reliever drug, but it does work really well with addiction-like symptoms, reducing crave as well too. And then if there's mental illness as well too, treatment of that. So, there's a lot of different ways. But again, primarily it's preventing this patient from going into fulminant withdrawal and not feeling like they have to use to stave off withdrawal.
Dr. Blair, is that what you're experiencing with women who are showing, and when you see them addicted to drugs, What's your experience around that?
It's just that. And with everyone, truly, the fun, whatever that high was, is long gone. People are fighting to just feel normal, to have some sort of baseline of functioning. So keep in mind, by the time we see them, people's lives have been in absolute shambles. It's true, right? So we were trying to get to like this level of clarity where maybe they could show up for work, or maybe they can show up for other family members and relationships that they already had pre-existing. It's truly a fight. Right. I'm really curious, are there any legal repercussions for a woman coming in to see you in an ER who has illicit substances in her system?
I'll tell you a brief story. So when I first graduated from residency from University of Colorado, I started working in South Carolina, and there was a landmark case. This is, I'm going to age myself, 2001, and a woman that was on crack, that crack overdosed. She had an abruption of the placenta, which is a premature separation of the placenta from the wall of the uterus. She bled out, almost died. Her baby died, and she was put in jail for murder.
Wow.
In South Carolina. I literally hadn't stepped a day in a doctor's office, and I was on the news talking about whether or not I thought it was right to charge a crack-addicted mom with murder. Wow. So there is an absolute fear around, for a woman of coming into the hospital, that this potentially could be them. And California is as like mom addicted friendly as they come. In the South, forget about it. Wow. I mean, it's a totally different set of rules.
And I asked this for barriers. I'm trying to understand the barriers for women to come and seek treatment.
Right.
And we discuss judgment and we discuss stigma, but I'm curious what other things that people would really be terrified of.
Yeah. They can't get off the couch. They can't get off the couch. The reason people use opiates a lot of the times, and the reason they're called painkillers, is because they work better on emotional pain than they do on physical pain. And we're a depressive society. Income disparity is getting worse and worse. It's getting harder. Careers are not careers any longer. You're changing careers every 3 years now. It's not like when we were kids and you could be, whatever it is you were. You work in an auto plant, for 30 years. Or
with a pension.
Right, with a pension. And, those days are over. Now, the technology, it's like every day, right? It's changing. So, I want to get back, if you don't mind, to the solution, one more time, because we can either talk about it or be about it. Mm-hmm. And, you're a big shot there, How would it be received if we put an outline together that said, hey, look, when they come in like this, right, when a pregnant mother comes in and she's showing or not, right? But it's not going to happen if they're not showing in this case, chances are, right? So if she comes in, she's showing, right? She has an accidental overdose. She's in the ER. How do we get Blair in there right away? These centers that will take people for Medicare and Medi-Cal and Medicaid and Obamacare and all these insurances that treatment centers don't typically take. So we put those in the portal. She then refers, gets them to pick them up, or you guys transfer them right to the treatment center, and we save a couple lives. How is that going to happen?
So I think going back to what we were speaking of, specifically to starting them on medication. So starting them on buprenorphine gets them to a place of, I'm not addicted, feeling trusted, feeling like I'm going to go along with this process.
Hold on a second. That's true. That's the first step. But they're not going to have, hold on a second. But they're not going to trust. She's the one that gets the trust, because not every doctor's like you. The patients that you have trust you because you're unusual. We need somebody, a social worker, who has the ability to connect and really love them and express to them how serious this is and that it's going to be okay, and then make the transfer and stay with this woman until they actually pick them up. That is how I envision it. So how do we get that done? Will the people be receptive to that?
If you don't treat the symptoms immediately when they come in, because a lot of these women come in, let's say she's 24, 26 weeks, 40 weeks is a completed pregnancy. They're coming in because they want to check on the baby, quote unquote. So we do an ultrasound, we check some labs, they get their prenatal labs done. They know the baby's okay. Let's say they're in withdrawal at this point. If you don't treat that, I don't care if you have Dr. Joyce Brothers, whoever it may be out there, as the greatest possible psychologist, social worker, counselor. If you don't treat those symptoms, you lose them. They're gone.
Because they're sick and they need to get well. So I get that, but
let me finish. So there's things called a warm handoff, which essentially is, once we've done that initial treatment, it's not give them a prescription, send them on their way, and have them follow up. Now, granted, follow-up is important when it comes to medicine, where we might not see a pregnant woman, every 3 to 4 weeks until she gets closer to term. These women need every week to every 2-week follow-up. But in that process, once we get them stabilized medically, because you have to understand, the majority of these women are not in a place mentally where they can hear from a Blair. They're so agitated and in withdrawal. If you don't treat that, I don't care who comes in the room, they are out. They are gone. So you establish that trust, a warm handoff. I have a relationship with you. I call you. I say, I need you to come. I need you to speak to this person. Whoever it may be. There needs to be an alliance. It has to be a team between medical providers and social work / psych. And we do not have that. And if that can't be done in the hospital, then to have a facility that's willing to come get that person, to take them into a coordinated treatment program, to me, that's the way to do it. And one where, the obstetrician in this particular case for pregnant women is in coordination with them. They're speaking to me, I'm speaking to them. I know how she's doing there. They know how she's doing with me. So it's a coordinated care system.
Sounds beautiful, really.
It is beautiful. But you're talking about the person, right, that actually has the wherewithal to come in and check on the baby. And that happens all the time because you're seeing it. I'm specifically talking about the woman who is overdosed or med seeking and going into the ER, right? And that woman is like, the baby is an afterthought, right? And so what I'm saying is there a way procedurally, right, to work it out with the hospital, right, to actually have this policy so that we can save the masses? I know what you're going to do, right? But you're one of one, okay? What I want is a policy that they have to follow every single time this happens. Is there a way to, listen, I don't care if you got to shame these administrators or shame the hospital system. That's okay.
Or incentivize them is probably their language.
Yeah. Okay. How do you incentivize them?
Right.
Right. I'm always looking for the punishing program.
Right.
Yeah.
Because hospitals encourage, as an example, when we take maternal transports from outside facilities, the hospital gets a stipend for every patient that they take as a transfer.
Can we get the opposite? Can we get them incentivized for everyone they send to treatment?
Right. I mean, it's a great idea. It's beyond my pay grade to understand how you go about that, but definitely from the standpoint of protocols, I mean, we live for protocols, and AI is going to generate protocol.
It is.
Where,
oh, that's great.
Where that'll really make a difference.
The insurance companies, okay, are all about outcomes now.
Yeah.
Right? It would seem that insurance companies would have a horse in this fight, right? I know that's wrong.
A dog. Whatever.
What is the
horse in the race?
Yes.
A dog in the fight?
Right. Both of them are good, right? It would seem that they have a self-interest in getting this transfer to treatment to prevent the ongoing med seeking and the ongoing survival.
Because the cost of treatment for an addicted baby is probably about $500,000.
Shut up.
Sure. I mean, it's an ICU stay for, whatever length of time, 5 to 7 days in the ICU on top of aftercare treatment. I mean, absolutely. If you could tackle that alone, you could probably save the healthcare industry $10 billion a year.
Well, there you go. That should get there.
That's the ticket, right?
I threw that pulled that number out of somewhere.
No, but I get it.
But
no, I get it. But it's basically it's not so much anecdotal. It's more or less field research for you, right? So, that's the ticket right there. That's the ticket.
Or even liability. Like, what if the hospitals were liable at that point? Like,
Sure.
They are the ones now responsible for the life of the fetus.
Yeah, but I think it's $250 for a wrongful death, and it's maxed out.
not,
Oh,
okay.
it is? Yeah, but they don't care. I like the fact that the CEOs, right, of these insurance companies are making between $30 and $50 million a year, right? And they're doing it based on, gains quarter over quarter, year over year. And I think that this is something that would be genius for certain companies. They'll all jump on, but you have a Cigna or an Aetna or Anthem or whoever it is, some stud walks in and says, no, this is the policy right here. Okay. And, everybody jumps on the bandwagon.
right. So if you took it from there's several programs across the country that are doing this. If you have it from an ambulatory standpoint where they're non-inpatient, and you take that mom who comes in overdosed in the ER, stabilize her there, and then Clinton actually wanted to do something similar to this, where you literally have a facility where you have Blair's, I hope you don't mind me referring to you as a noun, but
That's fine.
but you have Blair's, you have physicians trained in addiction. They don't need to be addiction specialists. They just have to have an interest. You have the potential to do ultrasound. This is very specific to pregnancy. Everything in place for aftercare, home visits, and those moms go to those places and get their care there. Then they come back to your facility for the big ticket, the delivery. So the hospital recoups that, right? But then the mom follows up in a specialty clinic that understands her affliction and is able to treat accordingly.
Can we get that in the continuing education protocols and programs to where guys like you, maybe you train a handful of guys and they're responsible for training a handful of guys and so on, right? And that is, we're educating OBGYNs right from the gate, right? So that they understand what these protocols are and they can identify the med seekers and the people who are overdosing and addicted. Is there a way to do that?
I mean, that's been a dream of mine, is to literally have a traveling circus to residency programs across the country to be able to do whatever symposium, an hour, 2 hours, half a day, full day, which honestly, it doesn't require much more than that to at least give them the tools to feel comfortable treating. It really doesn't.
And then they just have to give a shit and be a human being.
And therein lies the Blairs of the world to help fill the holes in that caring empathy.
I'm talking about
piece of
the
it.
doctors. Because, a lot of doctors are desensitized to the process of helping another.
But if we can get a drone to just 8 milligrams of this, I send you on your way. But then we have on the other side of it, the loving, caring people for that patient to go to and know that she's going to be judgment free and get care and treatment with people that understand. I mean, that would be amazing.
It would be a good idea, Blair. This is for you. Because I've spoken at a lot of these psychological universities, right? Wouldn't the seniors or the people who are about to graduate that have to do their hours, right? And they get out and they've got to do their hours. Wouldn't it be great? And they're altruistic at that point, right? Right? They're on fire. So they come out, they're trained in this, right? They go ahead and they do you, and their hours are actually signed off on by the hospital. That seems like, a cost-effective way to do it for everybody and really the best way.
It does.
If you had an important center where you had a reputation for treating people in a way that was, so globally effective, and then you bring in resident psychiatry, my field, whatever else, yes, it's not groundbreaking. It's done in many other areas. It really is. It's done in reproductive health services. It would be amazing.
It's even done in hospice, right? And these people are on the way out, right? This is something where they've got an 80-year life expectancy.
There's a separated fellowship for hospice care in medicine.
And there's a fellowship as well for treating mothers. There's one in Ventura. A friend of mine is interested in doing it, and she's an MD. She's 33. And, female doctors, the statistics of female doctors is on the rise. In universities is totally flipped now. There's more females than males. So I'm hopeful that...
I'm the only male in a 14-physician group.
Wow.
So
amazing. And I love that. Get them while they're fresh, not jaded, not towards the end where they're being desensitized.
That was my idea to deal with the homeless issue, right? Just you get one guy, it's the Pied Piper, right? 25 of them follow this guy because this isn't something that you can teach, right? I guess it is the problem is normally you can video yourself but you can't in the homeless population, right? Because if you're doing it that way, these people get creeped out and they don't want it, right? So that can't happen. But if you walk around with coffee and breakfast or whatever, sandwiches, whatever it is, right? Socks, jackets, blankets, whatever it is, and you're of service, and you have the conversation, and you can pull a couple people off the street a day and put them somewhere, it's magic, right? That's how I envision this, right? You go in and you have, I've seen the doctors walk in, you've got 4 guys in tow, right? And so same thing here, you walk in, you've got four of these trainees, these people straight out of school. They come on in, they see how you do it, and they branch out. And the next thing you know, they're training. And they don't have to do a bunch of hours. They can do, 100 hours of this and then become proficient. And they grab the next 4. Each one grabs another 4. And you can make a difference in a whole hospital in 3-4 months. Yeah. Right? And these hospitals are all chains now, right? And then they go to the next chain and the next chain, like you're at Memorial, that chain, right? They're like the 3rd biggest in the nation, aren't they? Okay. You could do that. These could be positions. And in every major city, you've got these psychological universities, right? And think about it. These people are such good. Most of the people that go in to be a therapist, right? They've got good souls. Right? Right? This is a good soul industry.
Yeah,
right?
Sure.
Can you imagine? That's not a hard sell to get them to, take care of babies and mothers. That's not hard at all.
And you're caring for 2.
That's right.
It's a good 2-for deal. Right?
Right. 3 or 4. Yeah.
Right.
Yeah, exactly.
All right. What else we got? This has been so productive. I don't even know what to say. I'm so grateful that the both of you came today.
Thank you.
Yeah,
I really am.
It at times feels like it really feels like an insurmountable problem to solve. When you treat a mom and a baby who doesn't survive, it'll haunt you.
But Kenny, I get it. Yeah. But you got to take the first step, man, on anything. Yeah. So if it was easy, everybody would be doing it. Right. You guys just got to drag these people across the goal line.
No, it feels really hopeful. It really does. Because to me, it's funny. I've had this conversation before, but when you have it and you realize, it's not that hard. It's not that hard to do it. And it's not that hard to get other people involved to figure out how to do it.
It's hard to start it.
It is.
It's hard to get people in power to get on board. Okay. And you really have to give them the credit, right? You have to, and you just have to be, hey man, you almost have to talk to them and make it their idea, right? So that,
true.
right?
Most
so that
things.
they're, right.
Right.
So that they're married to it.
Yeah.
I don't suffer that affliction. I'm always like, great idea, Rich. I really don't.
Hey, man, I don't.
the ego.
I don't need.
That is politics to a T.
I do not need credit. Credit is for politicians,
All right.
right?
Well, this has been really, really nice. And it's been a pleasure to talk with you, Blair.
Likewise, I look forward to war.
Yeah.
So, guys, thank you so much for coming. Before I leave, Kenny, how can they find you? If anybody needs you, how can they reach you?
Call my name and I'm there.
Right.
Isn't that a song?
Carrier.
You just call out my name.
Hey, by carrier pigeon or what, man?
You can reach me at KennethSpielvogel.com. I actually have a webpage, so happy to have you reach me that way. You can email me from there. I'm a faculty member for the UCI OBGYN residency. I'm affiliated with Memorial Care Medical Center, like you said. And I am reachable 24/7. I'm an obstetrician. I'm always up. So we never close.
I got one more question for you so that people can actually find you. How do you spell Spielvogel?
Like Spielberg, but Vogel. So Spielvogel.
Very good. Blair, how can they find you?
You can find me at Carrera Treatment, Wellness, and Spa. I'm actively working with them. You can Google them. You'll find their website. And you can find me personally at Dr. Blair Psy D on Instagram.
Outstanding. Thank you, guys. Oh, you were going to fact check me on something.
Yes, I have not been doing this for 20 years. I'm 39. That dates me a little older. Sorry, Doc.
How long have you been doing this, Kenny?
30 years.
Amazing.
Did I get that right?
Yeah.
Okay. All right, guys. Thank you so much.
Thank
for coming.
you.
I appreciate it.
Thanks for having me.
We're out of time. Please subscribe on YouTube, click the thumbs up, and leave a comment. Please subscribe on Apple Podcast and Spotify and leave a rating and a review. And share the We're Out of Time podcast with others you know who will get value out of it. See you next Tuesday.